Good afternoon. It's a pleasure to be here. My name, as you heard, is Dr. Vertilus. I'm, again, like Dr. Zellers mentioned, one of the new cardiology faculty at Children's. My interests include preventive cardiology, so hyperlipidemia, obesity, hypertension. So I'm pleased to talk to you today about the approach to the overweight child with dyslipidemia. Okay. In terms of my objectives, they are threefold. First is to review the epidemiology of pediatric overweight and obesity. Second, explore the morbidity associated with pediatric obesity. And then finally, we'll discuss the screening and treatment of dyslipidemia in this population. So, starting from the beginning, what is obesity and how is it defined? We all are very familiar, of course, knowing that obesity refers to excess body fat. But of course, body fat in of itself is impractical to measure. So we use proxies for body fat. And the one that is most popularly used in the clinical setting, of course, is body mass index, and is recommended across the age span. As we know, it varies with age and sex in terms of the guidelines, but there are no specific risk-based cutoffs to define childhood obesity, which is interesting. And what we use actually is a reference population from the 2000 CDC growth charts. Of course, we're all very familiar with this from our clinical practices, but let's just review so we're all on the same page. Of course, we know that obesity, or starting with overweight, greater than the 85th percentile for BMI, but less than the 95th percentile is considered overweight. Obesity includes those greater than the 95th percentile for BMI, and there's no agreed upon definition for severe obesity, but in this presentation, we'll refer to greater than the 97th percentile as severely obese. So this is pretty simple, right? And straightforward. Of course, we know almost nothing is. Let's look at a few pictures. So this is a picture of a child who is normal weight. His BMI is less than the 85th percentile on the CDC growth charts. Looking at him, to me, that makes sense. This is a child that is overweight, according to the CDC growth charts. So greater than the 85th, but less than the 95th percentile. I don't know if I would see this child and think of her as overweight. And finally, this is a child that's greater than the 95th percentile, so of course is considered obese. Maybe if I saw her, I would think overweight, obese, not necessarily. But as we all know, this is not what we're seeing on a daily basis. We're seeing the unambiguous, grossly obese child for the most point. And if you're thinking in your clinical practice that you're seeing more kids falling in this category, of course it is true. Let's take a minute to just look at the actual statistics. So from the NHANES data, and this is from 2010, starting from about the 1960s all the way up to 2008, you can see in all age groups that there's been a steady increase in the percentage of obese children here in the United States, starting at about the 5% range and going up to the upwards of 20%. And also, there is an increase in the prevalence of severe obesity. And what we see is that this is actually gender-related or sex-related. So the boys are getting heavier. Our heavier boys are getting even heavier. And not surprisingly, with most chronic diseases, there is significant racial disparities that we witness in obesity. Some of the most marked ones you can see here highlighted in the 6 to 11 age group. You can see that Hispanic boys really hover over non-Hispanic black boys and non-Hispanic white boys. And in the female range, in the 12 to 19 age, you can see that non-Hispanic black females are significantly more obese than their peers. And again, there's the cost. The cost of medicine and the cost of obesity is falling right in line. From the 2008 data, 9.1% of all medical costs in the United States were attributed to obesity-related problems, and that accounted for about 140 billion healthcare dollars. And you may hear this from parents in the office, family members maybe. Obesity, they're a chubby child and they'll outgrow it. Well, studies are showing now in our practice and our clinical experience is showing that that's not necessarily the case. Obesity in childhood does track into adulthood. And the relationship is stronger as the child ages. So older children are more likely to be, who are obese, are more likely to become obese adults. One study illustrated that 80% of obese adolescents became obese adults, and up to 40% of just the obese adolescents became severely obese adults, so greater than the 97th percentile for BMI. And with this comes the complications. I usually start off when I'm seeing patients for obesity-related problems, either in the cardiology setting or in our coach clinic, by saying that, of course, it's not about how you look. Everyone I see is beautiful. I start off by saying, of course, they're beautiful. But the issue lies in the medical complications. So from head to toe, we know about the medical complications that we see related to obesity. The ones highlighted here, obstructive sleep apnea and hypoventilation syndrome, we see very often. Fatty liver as well. The gynecological abnormalities in adolescents, PCOS, is also something that we encounter often. Osteoarthritis, not necessarily, but pains in the knees and the joints, also commonly encountered, and of course the coronary heart disease, including dyslipidemia, diabetes, and high blood pressure. So yes, there is a long list of obesity-related medical problems. Again, the one that I hadn't touched on but is just as important is the social stigmatization and discrimination, mental illness, and depression, including depression that occurs. So there are tons of reasons why this issue has to be very adequately addressed, but for the purposes of this talk, we are going to highlight dyslipidemia. So moving right along, we'll go into the cholesterol part of this talk. Before we start talking about dyslipidemia itself, I just wanted to give a brief overview of cholesterol metabolism, just so we know what we're speaking of when we get into the details. So I like to divide it and think about it in a few ways. Where it comes from, where it goes, and how it gets to where it needs to go. So of course we know that most of the cholesterol in our body is produced by our liver, but we obtain cholesterol from dietary sources, and those include animal-based sources. Meats, of course, cheeses, eggs, anything that comes from animals can provide you with a significant amount of cholesterol. And then it goes to the liver. It's made from the liver and it's excreted, by bile acids through the intestine. So that's the major way that cholesterol is excreted, through the intestine. And then there are feedback mechanisms that make sure that we're making enough cholesterol, but we're not making too much. And the way it gets there is by transportation of lipoproteins. So when we talk about cholesterol, in the clinical sense, we're usually referring to the lipoproteins. These are the protein classes that carry the actual cholesterol, which is cholesterol esters, where they need to be. Of course, we know there are different types of lipoproteins: VLDL, LDL, the bad cholesterol, IDL, HDL, and triglycerides. And the way I explain triglycerides to patients, because many of them are familiar with good and bad cholesterol, but they're not always familiar with triglycerides, is by saying that the sugar and the fat that you eat that your body does not absorb or burn off, so to speak, can be stored as triglycerides. So if you constantly are consuming more sugar and fat than your body burns off, you have the potential of having elevated triglycerides. And so why is this important? I included this slide on atherosclerosis to just highlight that. And so on the bottom, we see here that ages on the x-axis here, from clinically silent, 10 all the way up to 50. And in the normal healthy vessel, you see that it's clear, absent of any plaques or streaks. As we go along over time, Fatty streaks can occur in the vessels. And fatty streaks under the appropriate conditions, including endothelial dysfunction, that can actually develop into a fibrous plaque. The fibrous plaques can develop into actually atherosclerotic plaques and become occlusive. And of course, we know if these become occlusive and they break off, this is when we lead to the adult-related diseases of the coronary arteries, which include MI, coronary death, unstable angina, and stroke, among just a few of the problems. So how does this pertain to us as pediatricians? Well, is atherosclerosis a childhood disease? A lot of people don't think of it as one, but I'd like to think about it as something that actually does start in childhood, and that's why it's important to us. The Bogalusa heart study is one of the most famous examples of studies that actually address this issue. So it's one of the largest studies of a biracial cohort that looked into the progression of atherosclerosis in children over time, and they also evaluated hypertension as well. And what they found was that the prevalence of fatty streaks was up to 50% during childhood and 69% during young adulthood. One other interesting study was the Vietnam War post-mortem study, which was a pathological study of about 100 soldiers who died in combat in Vietnam. And these were healthy young recruits, of course, who made it into the Army. The mean age was about 22 years old. And when their coronaries were evaluated, 45% of them had gross evidence of coronary atherosclerosis, 5% of which was severe. So we know that atherosclerosis is a process that we need to be vigilant of addressing because the disease process occurs earlier than we actually think about. And so based on this, there were some dyslipidemia screening guidelines that came over the past year and a half that I'm sure you all are familiar with. And that recommended that universal screening, so a fasting lipoprotein profile, start at age 9 to 11. When you see them in the office, you're getting fasting cholesterol labs. Though this was wrought with some controversy, it was found that it is cost effective in terms of lives saved if the cholesterol-lowering treatment is applied to those identified with dyslipidemia. So of course, if you do something with the information that is identified, it's considered cost-effective. It should be noted that the screening should begin earlier, about 2 years of age, if there's significant family history involved. So if their parents, grandparents, aunts, or uncles, cardiovascular disease, dyslipidemia, sudden death at an early age, then you should be screening these children earlier in your office. Okay. I'd like to mention a little bit about metabolic syndrome because this is the picture that we're often seeing. And though the definition is not as clearly defined in children, what we see is that you have the overweight categories here where you see greater than 85th percentile for BMI, and of course greater than the 95th or 97th percentile for obese and severely obese. These children tend to have the following disorders that you see here in conglomeration. And what that is thought is, what we know about obesity is that it's an inflammatory state. So you have inflammation going on in your body, and it's thought that the inflammation that occurs adversely affects many of the cells in your body. And that leads to a picture of what we see with type 2 diabetes, high blood pressure, acanthosis, fatty liver, sleep apnea, and endocrine abnormalities in addition to dyslipidemia. Okay. So once you obtain the labs in your office, of course you need guidelines to understand what the normals are. So this is what we're typically targeting when we're thinking about children's cholesterol levels. Total cholesterol less than 170, LDL less than 100, HDL greater than 50, and triglycerides greater than 150, although sometimes I have a personal goal for the obese children less than 110. And so this is the cholesterol screening flowchart, so what you go through in your mind when you get the labs and see the results. So if you have a total cholesterol that fits all the guidelines that I just said, less than 170 total cholesterol, your HDL is fine, your LDL is appropriate, and your triglycerides are within normal range, you recheck them again in a year, and then every 5 years thereafter. But if you have a total cholesterol greater than 170, your HDL is less than 50, your LDL is high, and your triglycerides are high, that's when you implement the lifestyle modifications that we're all well aware of. Nutritional counseling, and we'll talk about this in a little bit more detail in later slides. Weight modification. It's also important to note ruling out secondary causes. Of course, with this screening that happens, oftentimes we get other labs. So you check fasting glucose as well, but thyroid should be mentioned as a cause of secondary dyslipidemia. So that should always be drawn as well if you're dealing with cholesterol labs. And in addition to other types of medical issues, also knowing that certain medications can cause abnormal cholesterol labs, and that includes birth control pills if you're dealing with the teenagers, and steroids, certainly anabolic steroids if you're dealing with the teenagers as well. So it's important to think of secondary causes of dyslipidemia. Then, once you implement the lifestyle changes, starting over-the-counter supplements, and we'll go into supplements in great detail in a bit. You take those, you recheck the labs in 6 months, and then if it's not improved, then you refer to us, preventive cardiology. The final profile I want to mention a little bit because this has a different flow diagram in terms of where you go. So if you have a total cholesterol greater than 300 and your LDL is greater than 190 and or a sudden death in a parent, this is a different type of picture and is likely familial hypercholesterolemia. And this is when you don't pass go, you directly refer to preventive cardiology. And again, this slide is just to highlight that, familial hypercholesterolemia. In the homozygote presentation, you'll have a total cholesterol most certainly in the high 200s, usually greater than 300s, and LDL in 200 range. The HDL and triglycerides, as we were taught in medical school, typically are normal. But it shouldn't be excluded. If you have a child that has greater than 300 total cholesterol and still has elevated triglycerides, you still should be thinking of familial hypercholesterolemia. And the reason why that's important is because you want to make sure that you do secondary screening of siblings as well, even if they don't fall into the pattern of obesity or other issues that you may think of. If the total cholesterol is this high, you want to make sure that you're thinking of FH. And your goals are to reduce LDL to 100, total cholesterol to 170. You eventually want to get to normal. There's usually about a 5 to 10% reduction over 6 months once you implement the whatever therapy that you decide to do, whether it's lifestyle, interventions, medicines, or over-the-counter supplements. So over time, you can get them to healthy cholesterol profiles. Let's talk a little bit in detail about what these different options of interventions incur. So therapeutic lifestyle changes. So when I think of therapeutic lifestyle change, when you're in the office and you get these labs and you're kind of addressing your parents and the patients themselves with things to do, there's only so much time and there's only so much education that you do at that visit. So I almost always refer my patients to nutrition. I think it's very beneficial to have them sit down, go over in detail the types of dietary changes that would be most beneficial in helping their particular cholesterol profile. You know, and at Children's, our nutritionists do an excellent job. And usually what they work on is reducing saturated fat to less than 10% of the calories and reducing cholesterol intake to less than 300 milligrams per day. It's also important that even at this first visit, you can add dietary adjuncts, and there's many, including fiber. Metamucil, the apple fiber wafers, are very delicious. They taste like cookies. The children love to take them. Usually recommend a pack a day, comes with 2 cookies, and it's a nice way of adding fiber into the diet. Plant stanols and sterols are also an excellent adjunct for reducing cholesterol, LDL cholesterol. And there are many examples that you can buy over the counter. They usually come in 450 milligram tablets, and I can go up to 900 milligrams per day with good reduction in, like I said, total cholesterol and specifically LDL cholesterol. And then you want to work on reducing weight and increasing physical exercise. And there are some specific things that you can tell your patients, and we'll talk about that in a minute. So again, dietary therapy. Dietary therapy alone can cause a 5% reduction in LDL. So if you do the things that you're supposed to do, that we all know we're supposed to do, low fat, low cholesterol diet, increasing water soluble fibers, whole grains, fruits and vegetables. Brussels sprouts are up there, and we know everyone loves Brussels sprouts, including kids. So a lot of this is not realistic. And I'm new to this, but what I have learned is that there are some ways to get more vegetables in not only adult diets, but in children's their diets. So what I have recommended to get more vegetables in kids is green smoothies, so simple smoothies. Start with ice, you add kale, spinach, and then you add the fruit to it, and water or almond milk, and they're delicious, and children love it. So you can get a high amount of fiber, you can get your fruit in a serving of a green smoothie a day. So that's one kind of practical recommendation that you can give to your patients. And then of course, in terms of the selection of the oils, unsaturated or polyunsaturated fats, omega-3, omega-6 as well, and nuts. And we'll talk a little bit about omega-3 next, I believe. So what about nutritional management in terms of the treatment goals? When you're dealing with obesity, I usually say over the 4 to 6 month range, you want your patient to shoot for a 5% weight loss goal. So you just do the math for them and say, this is what I would like for you to shoot for. A common thing that I notice is that a lot of people will come back to the clinic and not realize that their child has gained 10 pounds. And that's because they're not weighed. And so in the coach clinic and in my personal practice with obese children in the preventive cardiology world, what I would recommend is that, first of all, get a scale. A lot of people don't have scales. And then weighing the child once every 2 weeks. So not more frequent than that, but just so that they can have a sense of the trajectory. What are they doing? What can they make better? Or if they're doing really great, they need to keep up exactly what they're doing. And of course, we don't want a very rapid weight loss, because especially in our younger children that still have a long way to go in terms of height, we want to make sure that they maintain that and that there's no deceleration of height growth. So metabolically safe, causing minimal hunger, and preserving lean body mass, about a 5% weight loss or approximately 0.5 kgs per week is a safe goal to give for not only the severely obese children, but our obese and overweight children as well. And our First Lady has done a wonderful job about promoting healthy lifestyles with Let's Move campaign. And it's appropriate to give your patients very specific guidelines in terms of what they can do and how they should be doing it. So a lot of the PE programs, unfortunately, don't provide the aerobic exercise that kids need. And what the specific recommendations are: 60 minutes of aerobic activity 5 to 6 days a week. So the kid that's not doing anything, obviously you can't give instructions for them to do that. But over time, you want them to gradually build up to that goal. Everyone needs a rest day, so it definitely shouldn't be 7 days a week. Aerobic activity alone can cause improvement in your cholesterol labs, increasing your HDL up to 15%, decreasing your triglycerides by 20%. And of course, we know the other benefits of exercise: increasing your lean body mass, decreasing your body fat, improving your overall cardiovascular fitness, improves your mood, reduces depression. The list is endless in terms of the benefits of safe aerobic exercise and activity in our lives. And so this is a list of the over-the-counter medications that I use most frequently, and you may use them as well. Niacin is the most effective way to increase HDL and decrease triglycerides, and also decrease L-little-PA, which is the most atherogenic portion of LDL. It's not measured, or frequently not measured on the labs that we get, but it's important because it causes the most damage long term. B-complex vitamin does a great job in increasing LDL. The plant sterol and stanol esters, as I mentioned, reduces LDL. Water-soluble fiber brings your LDL down. The omega-3s and omega-6s do an excellent job in of themselves at reducing triglycerides. And we'll talk a little bit about natural statins as well. Red yeast rice. So again, niacin. It's not as popular in the pediatric world because of the side effects, which we'll talk about in a little bit, but it's very effective. And if you give the appropriate instructions to your patients, most of the children I have on niacin tolerate it very well. You see the doses there. The appropriate instructions would be to make sure that they take the niacin with meals, that they avoid hot beverages or exercise or anything hot around it, because that mitigates the vasodilation and propitiates what we all learned in medical school, which is that horrible flushing. And it's not only limited to the face, it can cause vasodilation in the intestine as well, causing diarrhea and lots of bad things if it's not taken appropriately. B-complex vitamin is also a great tool, and it works to increase your HDL. So in addition to exercise, which definitely can cause up to 15% or 20% increase in your HDL, like I mentioned, B-complex is another vitamin supplement that you can recommend to these patients. I usually start 50 milligrams, less than 12 years old, 100 over 12. It comes in liquid forms. So this is the example of Nature's Bounty, the brand that I use the most, and again, very effective in increasing your HDL. Plant stanol and sterol esters come in a variety of forms, so chews, margarine, chocolates. There are different types of forms of plant stanol and sterol esters, and they work wonders on reducing your LDL. It's a great place to start. Cholesterol is the most popular brand name of that, and you start at 1 tablet and you can go up to 4 tablets daily. And of course, we all know about omega-3 and omega-6. Even patients who come in with triglycerides greater than 400, I typically start them on omega-3 and omega-6 because it does work that well. It can cause up to a 50% decrease in your triglycerides. I usually start at about 1,200 milligrams, but you can work yourself up to 3 grams per day, and it comes in a variety of forms. Capsules, liquid, the gummy is the most popular. They have these sippies here. So it's an excellent way of working on that metabolic, atherogenic cholesterol profile that we see most often. In addition, there are other grains and supplements and seeds that you can add to the smoothies, for example, that will also decrease your triglycerides. This includes flax seeds and chia seeds. So chia seed, the same thing as the chia pet, chia pet. So chia seeds have so much nutritional benefit, including high protein, high fiber, but for the purposes of this talk, also very high amount of omega-3. So it's a nice thing to put on your smoothie or mix into any liquid. It does cause a gelatinous form, so it can make a pudding out of it. Something that you can explore in terms of providing additional benefit for omega-3 and omega-6 in the diets. And I usually recommend 1 tablespoon of chia seed per day. Cold water fish, of course, we know is very beneficial in terms of its value of omega-3, but most of our children are not consuming cold water fish. And omega truffles, another chocolate variety. Red yeast rice is nature's statin. So essentially red yeast rice, when you look at the biochemical properties of it, is the same thing as Mevacor. So it is a statin. Therefore, it works in reducing LDL, up to 30% reduction in LDL. The advantages: it's well tolerated, it's inexpensive, it's over the counter, and parents are more willing to use these types of medicines than statins. And we'll talk a little bit about statins and when we use it in this population. Nature's Bounty, again, is just my personal preference in terms of brands. And you start at 600 milligrams and you can work your way up to 1,200 milligrams of red yeast rice. Nature's Bounty comes in a capsule, and you can open it up and mix it in puddings or applesauce. It has no taste, and it works really well. So, of course, they're the prescription medications as well. And I won't spend too much time about this, but just to remind you what they do. The statins, of course, reduce the LDL. Bile acid sequestrants reduce LDL. The fibrates reduce triglycerides and increase LDL. And I've seen they also work pretty well on your LDL as well. And then they're cholesterol absorption inhibitors. This is just a list of the statins. As we know, it can cause liver toxicity, and increasing doses, especially in conjunction with fibrates, you have to be very careful for the rhabdomyolysis and sleeping disturbances that may occur with them. So a little bit about statin therapy and metabolic syndrome. We know that the American Academy of Pediatrics does recommend use of statins in children with FH, starting at 8 years of age. But kids with metabolic syndrome and severe dyslipidemia should also be considered as candidates for statin therapy. Also in those age ranges greater than 8. Long-term benefits for statins include preserving endothelial function and just overall reducing inflammation. So when do you intervene? When do you start these over-the-counter supplements or medicines? Of course, the treatment for FH and metabolic syndrome will differ. But like with most things, the earlier the intervention, the more effective the results, and the more compliant your parents will be, and the more willing, hopefully, the child would be to change their behavior if you're starting things early. Again, this slide is just to highlight what FH looks like so that you know that it's a different ball game than the title of this slide, which is the approach to dyslipidemia in the obese child. The metabolic syndrome profile is what we're dealing with and what you see most frequently when you get abnormal cholesterol labs. So that usually entails an elevated triglyceride level, normal or maybe mildly elevated LDL, and a decreased HDL. Okay. And your goals are to reduce your triglycerides and get your HDL up. These are just next slides just talk a little bit about the meds that we use in treating cholesterol issues. Bile acid sequestrants work well on LDL, up to a 15% decrease in that. Horrible side effects, so we don't use them that much in kids, cause bloating and flatulence. Fibric acid is something that I do use fairly frequently when you don't have the appropriate or you don't have enough effect of omega-3s when you're dealing with elevated triglycerides. Fibric acids work wonderfully for that reason. So they reduce triglycerides up to 30%. Like I said, you can also see some effect in your LDL, and you have increased HDL as well from these medicines. Again, you use them cautiously because there is a combined effect in terms of the side effects when used in conjunction with statin medicines. Zeti is another med that works in the intestine by inhibiting cholesterol at the brush border. And Vytorin is another med that you may or may not be aware of. It's the combination of Zocor and Zeti, and the advantage is using a smaller amount of the statin drug, and you have the effect of tripling the dose of the statin. So you have a smaller dose of the actual statin, but you have more effect with the combination. And the following slides just go over a few profiles. So I'll just read them out, and anyone can just chime in and tell me what they think about the profile. So this is a kid that you see in the clinic, total cholesterol, 9-year-old, total cholesterol of 235, triglycerides of 90, HDL of 46, LDL of 173. What do you think? Anyone? What was that? I'm thinking that you said that you could do some of the things that I have listed here. Usually would start off with maybe some dietary fiber, doing the basics in terms of just natural lifestyle interventions. Plant sterol and stanol esters would be a good choice for this. Maybe red yeast rice, but I think you would be able to get the effect from the first two. And last but not least, which you probably wouldn't be doing, but statin therapy would be the last kind of resort. What about this one? Total cholesterols of 255, triglycerides of 317, HDL of 27, LDL of 165, BMI of 35. What was that, sir? What'd you say? Huh? Right, get an ECG. That's always a good answer from a cardiologist standpoint. So yes, you would do that. And you would address this, abnormal cholesterol profile by starting, of course, dietary fiber, plant stanols, but the triglycerides are significantly elevated. So you would focus your efforts on trying to get that down with omega-3 and omega-6, maybe niacin if that didn't work. And finally, fibric acids would be where you would go eventually if you didn't get the result with those two. And what about this one? Total cholesterol of 304, triglycerides of 109, HDL 39, LDL 243. What was that? Call me, yes, call me, Dr. B, anytime. So, of course, this is a FH profile, and you would refer to cardiology and screen the siblings as well. And that's what I have. Thank you so much for your time.